Thanks, Alison, and thanks everyone for inviting me here to speak to you today. So we'll be talking about repository radiographs in the yearling, lesions that are significant and also ones that you'll come across quite commonly. So just a summary of what we'll chat about today. We'll take it back to, what are the repository radiographs? What is it that we as veterinarians are looking for on those images? How do those findings relate to the sort of racing potential of the horse going forward? We'll run through the individual lesions that we'll find, and then what is the value of the radiographs to the sale of the horse. So firstly, just the basics, what are repository radiographs? They're a standardised set of radiographs that we take within 6 weeks of a thoroughbred sale, and they're normally lodged within 4 days of a sale. Typically, we'll carry out those radiographs on farm. Smaller sellers with 1 or 2 horses will occasionally bring them into the clinic for ease, but most of the time we'll take these out on farm. It's a set of 36 very specific views. The goal is to highlight areas that we know are of higher risk for having lesions that may be of potential significance later on to the horse. So those views include the front feet, all 4 fetlocks, the knees, the hocks and the stifles. It means that we're not x-raying sites like the elbow and the shoulder, which are areas that we do know can have OCD lesions, but at a much lower risk, much lower rate than other sites. Other sites such as the hind feet, the neck, we're not imaging. At the end of taking the radiographs, we'll take them back to the clinic, we'll interpret them and we'll produce a radiographic report for the vendor. When we interpret these radiographs at sale, we'll also produce a report then for the buyer, whether that's written or verbal. So as I said, there's 36 views, which is quite a lot that all need to be taken to a specific standard so that we can see the areas of concern, and then we all need to sit back and read them once they're taken back to the clinic. One of the nice things about our radiology team at Scone Equine is that we'll send out quite a team of people to take these images. So we'll send out someone to take the radiographs, someone to hold the plate, and someone, often our radiology department head, to sit there and read the images as they're being taken so that we can check that the positioning is adequate. If there's any subtle lesions or areas of concern, then we can take some additional views, and hopefully we can minimise our risk of sort of having to come back to the farm on a separate day and take some follow-up views or some further views of the horse. So what is it that we'll find? As we said, there's a very specific set of views. We're looking to highlight areas that we know can have particular lesions that are common in this age group of fast-growing thoroughbred horses. So things we're looking for are your developmental orthopaedic disease specific to the joint, so being your OCD lesions, whether they're fragmented or not, subchondral bone cysts, fasciitis, and then other problems such as sesamoiditis, fractures, bone fragments, osteoarthritis. Our focus is mainly on bony changes, that's what a radiograph shows us, but we do get to see, in some cases, soft tissue changes, the most of which is probably joint effusion or swelling in a joint that may be associated with some of these lesions and suggests that they are sort of active and clinical. So why is it that we do it? What's the point? They're basically to provide the buyer with a guide for their purchase. Lameness is one of the leading causes of poor performance in thoroughbred racehorses, so it provides the buyer with more information for their purchase, highlighting areas of potential problems or potential concern, but it also then enables the buyer to design and manage the horse's training and racing program going forward, whether they need to take the horse a bit more slowly or modify the way that they manage the horse. It's important to point out that it's not a pass or a fail. We will provide a risk rating for the horse. Again, if you buy a horse that we consider low risk or has minimal changes, it's not a guarantee that the horse, will be perfectly sound. It may develop changes 6 months down the track or have problems in future, but it's a snapshot of that horse at this point in time. The guide is also based on the veterinarian's experience and their opinion, and then the buyer needs to take on board these radiographic findings in conjunction with their own sort of breeding analysis, the type of racing that they're looking to do with the horse, the conformation of the horse. And then we as veterinarians can also provide additional information apart from the radiographic findings. We can also perform clinical examinations of these horses, so listening to their heart for murmurs and arrhythmias, checking eyes for scarring, internal cataracts that can affect vision. We also assess the conformation of the horse. You'll hear from Lucy a bit later on today about the endoscopic exam, and that's some further information that we can provide about the horse for a buyer. So as we've said, it's important to appreciate that these are not a pass or fail. We'll provide a risk rating, which is a graded scheme from low to high risk. So your low risk horses are horses that have no or very minimal changes that are unlikely to be of any future clinical significance for the horse, all the way through to high risk horses that will have radiographic changes that are highly likely to be associated with lameness and affect the horse's ability to train and race. Many of our horses fall into the low or low to moderate risk rating. So a horse that's low to moderate risk will have minimal changes. They're either unlikely to affect racing, or if they do go on to require treatment, generally we'd consider them to have a good prognosis with treatment for going on to race. It's important to highlight that the opinion towards risk really varies. You can have multiple vets read a set of radiographs, describe them all in slightly different ways, and relate them back to individual people in different ways. So the experience of the veterinarian comes into play. Ideally, people reading repository radiographs would have some experience at the coal front, working in the racetrack, knowing what these horses are like when they do go on to race, as well as having some experience, in the thoroughbred nurseries, watching these horses grow and develop and how these lesions can change and progress. In conjunction with providing our own experience, our relationship with the buyer then is also important. Individual buyers are going to want different things out of their horse and out of their purchase, whether they're looking to take the horse on to race themselves, are they looking to pinhook it, are they wanting to sell it at a ready to run or export it to Hong Kong. Are they willing to take the horse slowly? Are they looking for a horse that they want as an early 2-year-old to target sort of the big ticket 2-year-old races? And then in terms of risk aversion, everyone's really very individual in what sort of level of risk they're willing to take on. No matter what we say, there will be people that will only want to buy low-risk horses and minimise their chance of having a perceived problem. You might find that an individual buyer that's picking up one horse every couple of years really wants to minimise his chance of having a problem with a horse that he can go on and race successfully. But those sort of people, they will miss buying horses that can be highly successful on the track for sure. You might find then that people that are picking up multiple horses at multiple sales are a bit more willing to take more risk on lesions that can be managed. In terms of price, in my opinion, that really comes down to the buyer putting all of this information together as what they're willing to spend on a horse, and that's not down to the veterinarian. So now we'll go on to actual individual lesions. I guess it's important, I'll try and give you guys an idea of risk ratings for some of these lesions, but they are very much just a generalisation. It may vary with individual horse, the appearance of the radiograph on the individual, and again what the purpose of the buyer has for the horse. So starting down with the foot, we get a good idea of the pedal bone here. Modelling that we may report on pedal bones, referring to modelling that may be on the dorsal hoof wall here. The other change that we'll see occasionally is ski tipping or modelling right down on the toe. In horses without overt laminitic change or rotation, that's really a low risk finding. It doesn't tend to have any significance on the future potential of the horse. Fracture really depends on the type of fracture that is present, so that can be quite variable as to the risk of the horse. Conformation, we do, as you can see, get an assessment of the soft tissues on a radiograph as well, so we can appreciate the hoof capsule as well as the pedal bone angle within the foot. So if a horse has a club foot, we can potentially pick that up from a radiograph. We can lay down the left and the right radiograph together and get a comparison of the feet. So we can give people an idea of that from the images. Pedal bone cysts are relatively uncommon and they can be quite subtle and hard to detect. This one's actually fairly obvious. They tend to be more of a higher risk problem. They can be quite often associated with lameness at some point during the training preparation, and their response to treatment can be variable. So they tend to be potentially a bit more of a problem for the horse. Moving on to the knee. So there's 3 sets of views that we'll take of the knee. And Particularly dorsal carpal disease, spurs and fragments can be of reasonable amount of concern. The dorsal carpal disease refers to roughening, new bone formation on the front of the bone. This is where the joint capsule of the knee inserts onto the front of the bone. So roughening there at the joint capsule attachment is a sign of early arthritic change. This horse also has a spur, so squaring of the radiocarpal bone. It's quite lucent, so it's quite dark. I'm not sure, sorry, how well that's going to show up for you guys up the back. So that lucency suggests that that bone is softer than it should be. When we're looking at the knee, we've got the middle joint through here, which is sort of the bigger movement joint in the knee. Changes here tend to be of more significance than if they're in the upper joint. The upper joint tends to be a lot more forgiving to change, and horses tend to be more tolerant of that. So we may rate changes here lower than we do in the middle joint. This horse has fairly significant change, and he would be, a moderate to high risk horse for that, having potential to cause lameness during training. This horse just has a small chip off the radiocarpal bone without any other changes in the joint. Surgically, if you clean that up, you would expect that horse to be lower risk because there's not a lot of secondary changes, and provided you didn't see anything more at surgery. However, people would be, as a buyer, somewhat wary because it is a middle joint change. Some of these horses you'll find that have that early change, they may be the more offset horses or the heavier horses that are loading through their knees. Bone cysts, again, so the ulnar carpal cyst, which I haven't provided an image of, is a cyst that can occur in this ulnar carpal bone on the outside of the knee. It's actually a relatively common finding. 35–40% of horses will have a cyst in that bone. We know it's of no clinical significance to the future racing of the horse, and a lot of veterinarians actually don't include it on their reports anymore because it is of no significance to the horse. The ones that we tend to get concerned about, though, are cysts like this one in the bottom of the radius, in the radiocarpal bone here, and potentially at other locations. They're generally are more of a moderate risk horse. They have a variable likelihood of producing lameness in training, and they can have a variable response to treatment. Accessory carpal bone fractures are not that common. Significant ones sort of through the body of the accessory carpal. Those horses potentially can perform well, but at sale they are a little bit of an unknown entity. Just some of the interesting ones that you may see some different lesions sort of pop up on your reports as they're coming through. We do sometimes see mineralisation of blood vessels. Like this one at the back of the knee is a fairly common sight that we will see it. It's of no significance to the horse. Moving on to the fetlock. So we have 4 sets of views that we'll take. A lateral, flexed in the front, just standing in the hind, 2 sets of obliques and a DP. I just thought we'd touch on a sagittal ridge OCD. These are a lower risk problem, but it's something that you'll see quite commonly come up on your reports. So I thought we'd just quickly mention those. It's very common to see what we call dorsodistal sagittal ridge OCD on the bottom of the cannon bone. These lesions can be either a lucency, sometimes they'll have fragments or fissures in the bone or the cartilage, but generally they're a lower risk lesion. They do generally tend to heal with time, so a lot of times we will report them and just list them as a low risk with time. They may not necessarily be an early 2-year-old, but with time they generally do very well. We also see fragments at the top of the sagittal ridge, as in this horse. Generally, a lot of those will heal, sometimes they remain. In the hind fetlock, we tend not to worry about them. In the front, if they're large, we may recommend removal. Chips and fragments. So when we're looking at chips in the fetlock joint, things that we need to take into consideration, are we looking at a front leg, are we looking at a back leg, are we looking at the front of the joint or the back of the joint? Chips in the front of a forefetlock, we generally will still recommend removal of those prior to sale. We know that chip fragments in the front of a fetlock can be associated with lameness in racing horses, and there is sort of increased loading and extension through the forefetlock during galloping. Hind fetlock, dorsal P1 chips, there was an early study, sort of survey out of the States that suggested that hind fetlock P1 fragments were associated with a poorer, or a trend for a poorer racing prognosis. And originally people were taking these out prior to sale. We know clinically that these lesions are chips in a hind fetlock are very rarely associated with lameness in a racing thoroughbred. So smaller and medium-sized chips, we're just recommending that people leave them in and of minimal significance to the horse. If they're quite large, there is the potential for some irritation in the joint, and we may recommend removal prior to sale from surveys, but generally they are of lower risk. Interpreting some of these bigger surveys that have done of sort of racing potential on these horses, really as a veterinarian, it's where your clinical experience can come into play as well. There was recently just a study out of Japan. It was a smaller study, but showed again that hind P1 chips were associated with a less likelihood of racing. But when they followed up a lot of their horses that didn't actually make it to the races, not one of them didn't get there because of the radiographic lesions. It was something else. So we probably really need to be careful of putting together big surveys with our clinical experience of what we know actually happens on the track. Fragments in the back of the joint, so generally sort of little P1 fragments. In the thoroughbred, they're of minimal clinical significance to the horse. We know that in the standard bred, in hind fetlocks particularly, they can be of more significance. But P1 fragments in the back of the fetlock in a thoroughbred typically don't affect the racing prognosis, and we don't tend to go chasing them surgically. They're a lower risk horse. We do also see what we call eminence fractures or fragments, so we can actually have what can look quite significant fractures through the back of P1. They're not uncommon, and they generally always heal, and they're of no significance to the horse. Bone cysts in the fetlock, similar to the knee, are probably more of a moderate risk horse. The variable likelihood of resulting in lameness and a variable response to the treatment options that we have. I've just included a picture of supracondylolysis. We don't see it that commonly, but you may see it pop up on your reports. May not seem that significant on this x-ray, but it's actually sort of necked in 5 millimeters on this horse. So we're looking for a depression in the back of the cannon bone above the fetlock joint. It may relate to chronic joint swelling at some time point in that horse. When it's quite marked or severe, it actually can be associated with the reduced raceability of the horse, so they may be more of a moderate risk type horse. The sesamoids at the back of the fetlock, a number of things that we look for here. So sesamoiditis is something that you'll see pop up quite commonly. The name in itself suggests an inflammation of the sesamoid bone. In reality, it's probably more of an adaptive or maladaptive response to abnormal loading through the sesamoid. When we're looking for significant findings, these linear lines are what we consider to be blood vessel channels. We become concerned when there's more than two of them. They're wide or they're bizarrely shaped. If there's lucencies that extend into roughening on the surface of the sesamoid bone. There's a number of studies that suggest that these horses are less likely to race at 2 and potentially 3 years old. We know clinically that young horses, these lesions, if they're significant, may not stand up as well to early racing, or they become clinical, the horses become painful and lame. So these horses tend to be more low to moderate risk with time. They don't tend to make, 2-year-olds with the potential for the lesions to cause lameness. One of the things that these sort of sesamoid changes can highlight is that, as we said, we're only looking at bony change. What we don't get an idea of from the x-ray is what the soft tissues attached to those bones look like. So our suspensory branches come down and join on to the sesamoid bones. We don't get an idea of whether there's any soft tissue change in that suspensory that may also have a bit of an impact on that horse going forward. Fracture of the sesamoids, one of the common ones that we'll see are what we call apical fractures. These are not an uncommon injury in foals, weanlings going through, and we'll see them often in survey x-rays. In young horses, we tend not to go chasing them to remove. We'll give them a chance to see if a lot of them in foals and weanlings will go on and heal, so we'll monitor them radiographically. By the time they get to sort of yearling surveys and sale, if they haven't healed, we do tend to recommend removal of them. Having a chronic sort of malunion has the potential to result in lameness, but typically it would be considered to have a good prognosis in most locations aside from the front inner sesamoid. It's probably the one sesamoid of the lot that takes extra loading, so it's the one that may have a slightly lower prognosis going forward. When these fractures in young foals, weanlings, do heal, you do often end up with an elongation of the sesamoid. That doesn't tend to have any clinical significance on the horse going forward, even though radiographically the sesamoid will be somewhat abnormal. Modelling, that refers to spurring of the sesamoid, or we may also see what we call enthesiophytes, which are spurs where some of the soft tissues attach. Depends on the location. Generally, clinically, we get less concerned about a hind than a fore fetlock. If it's significant in a front, we may attach a degree of risk to that lesion. When we x-ray a fetlock, we also include the pastern joint in the bottom of the fetlock x-ray. Some of the lesions that we'll see are lucencies, which are basically just little shallow depressions on the joint surface. Typically those, no matter where they are of no clinical significance to the horse. In this location, they don't tend to progress or result in an issue for the horse. What we do get concerned about are bone cysts, as in this horse here. They, again, have a variable potential to result in lameness and a variable response to treatment. One study suggested a lower chance of starts at 2 to 3 years old. It's not a common lesion that will diagnose with lameness in racing horses, but we do know that if lameness develops, it may be somewhat harder to manage. Fragmentation and mineralisation we'll occasionally see at the back of the pastern joint. Clinically, it doesn't tend to be a big problem for the horse, so there's often not a large degree of risk associated with that. Moving on to the hock, so we'll start off with the upper joint, which is the tarsocrural joint through here. This is a joint that has all the motion and the movement within the hock. Firstly, just to touch on fracture, lateral trochlear ridge fractures, horses can actually fracture off this whole beak of the lateral trochlear ridge. Tends to be more something that we diagnose clinically as an acute lameness rather than something picked up on a sale x-ray. It's not common. Clinically, our impression is that those horses actually do quite well, but they would probably have a higher risk for sale, as people may be somewhat wary of those. Fractures of the talus, we can see fractures of the distal lateral trochlear ridge, so small fragments just here which do communicate with the proximal intertarsal joint. There was a nice paper out of Scone that showed that those lesions do tend to go on and heal, and they're of no future clinical significance to the horse, despite them involving the joint. So OCD lesions, one of the most common lesions that we'll see are what we call a dirt lesion, so the distal intermediate ridge of the tibia. These fragments, size doesn't really matter. Without removal, they're more of a moderate risk. They are a reasonable chance of resulting in joint effusion or lameness or displacing. Not all of them will become clinical. Spotted on sort of survey x-rays, we do tend to recommend removal with a good prognosis with surgery and a low risk course once they're removed. The medial malleolus is probably our third most common location for lesions. One little thing with this location, you can appreciate hopefully, that this horse does have a degree of joint effusion, so we can just make out the soft tissue opacity of the joint sort of bulging out through here. Similar to the distal intermediate ridge, with removal they carry a good prognosis, a low risk for racing. The one thing is that this particular location can be associated with chronic sort of longer term joint swelling and effusion. It is more of just a cosmetic concern, it's of no significance to the horse. If we just go back, so the lateral trochlear ridge OCDs that we see down the bottom here most commonly, the majority of these either heal with time or sit tucked away on the bottom of the trochlear ridge. Unless they're large or multi-fragmented, we often start to leave those alone because they tend not to bother the horse. Moving on to the lower joints of the hock, so these are the joints down here. These are really the shock absorbers of the hock joint. Things that we're looking for, dorsal modelling refers again to bone reaction on the front of the bones. Spurring, one of the common sites that we'll see is on the top of the cannon bone here. This horse obviously has a lot of changes going on, but if we just see some reaction out the front or a small spur at the top of the cannon, those horses really are low risk horses. They don't tend to be associated with problems going forward and racing. This horse here has what we call wedging of the third tarsal bone, so you can appreciate there's a depression in this bone here. It should have a nice parallel, even joint spaces across all three lower joints. This would have come about, this horse was probably premature. Normally when a foal is born, these small tarsal bones are fully ossified. If they're born premature, they can be born with them still as a cartilage precursor or only partly turned into bone. If they run around too much, there's a risk that cartilage can become squashed, and then as it does go on to form into bone, potential for deformation of that bone. It is associated with a lower risk or lower potential for racing. This horse has secondary arthritis through the joint, so you can appreciate this one. This joint space here, we can see a nice black space through the joint, whereas these two lower joints, it's blurred out. So there's significant arthritic change across this joint. This horse actually was sound as a 3-year-old in training, and the reason that probably is because these joints have no doubt fused. It doesn't always fuse, and it can be associated with lameness. It's a difficult horse to sell. Just touching on fracture, because these do pop up not uncommonly. There's a little linear lucency through this bone here. This horse has a third tarsal bone fracture. We can see slab fractures where it fractures all the way through the third tarsal bone. Sometimes they're incomplete, like this horse here, where it doesn't extend all the way across both joints. They can result in quite a bit of modelling and bone reaction out of the front of the joint, which can look quite significant. Again, we did a nice follow-up study through Scone, which showed that once these fractures heal, even if they have changed, they're of no significance to the horse. They don't tend to end up with a lot of bone reaction across the joint space. It's more just reaction out the front. So that horse would be a low-risk horse despite having a fracture there. Finally, moving on to the stifle. So the most common OCD lesion that we see in the stifle is on the lateral trochlear ridge. And this is one of the locations where size does matter. Lesions that sort of are less than 4 centimetres in the joint with surgical removal have a low risk for racing. Without removal, they have a reasonable chance of becoming clinical and needing surgery down the track. Over 6 centimetres in length, you're tending to run into fairly extensive loss of joint surface, and that may be that it's one large lesion or you've got multiple lesions in multiple sites. If they're extensive, there's a reduced raceability for the horse. Lucencies, so again, these are quite common changes. This horse just has a shallow lucency, it's a little almost dimple-like on the medial femoral condyle. On its own, that lucency is unlikely to have any clinical effect on the horse going forward. There is a risk that these lesions can go on and progress into more substantial, deeper subchondral bone cysts. That may be more likely if we see deeper bone change starting below that lucency, so we may start to get an increase in bone density through here, or deeper lucencies just starting to develop. There was a recent study that suggested that 3 to 4% of these lesions can go on and progress into deeper bone cysts. That study also suggested that this particular lucency may be associated with reduced racing at 2-year-olds. As a 2-year-old, clinically, it's not something that we tend to diagnose. there's the potential that those horses might just go a bit sore and the trainer turns them out. But certainly we don't commonly associate lameness with this particular lesion on its own. It would have a degree of risk associated with it just for that small potential that it may progress into something more significant. We also see lucencies we call on the axial surface of the medial condyle. We sometimes see them on the lateral. They tend to be of lesser significance. Then the bone cyst. So this guy has a big bone cyst in the medial femoral condyle. There's some sclerosis or increased density around the cyst. Not all of these are going to go on and cause lameness. There's some really good horses racing out there with these lesions, but there is a potential for them to cause a significant lameness. Again, that can be difficult to manage. We have got a number of good treatment options out there for them, but they tend to fall into the moderate to high risk category just for the potential of a difficult to manage lameness. We'll occasionally see bone cysts in other locations like the tibia with a similar sort of degree of risk. Patellar fractures are not that common to see on a survey radiograph. If they're not too large, they do actually have a relatively good prognosis with surgery, but are more of a risk if found at repository time because of the unknown with the horse. Just another unusual lesion that you might see pop up on your reports from time to time. These ones are kind of cool. We call it a calcinosis circumscripta, which sounds terrible, but it's actually just a random spot of mineralisation that we can see most commonly just on the outside of the stifle. We don't really know why they develop, whether there's been some trauma in the area, but they're not of any significance to the horse. So then what's the value of the radiographs? Really, we're looking to give the buyer some confidence in their purchase, and it gives them an idea of how they can manage the horse going forward with their training and their racing preparation. You know, a buyer that has a horse with the perfect type, the perfect pedigree, then finds there's some changes on the x-rays that may not necessarily turn them off the horse, but they may know that they need to take the horse slower through its preparation than they originally intended, but they can maximise the racing potential of the horse. I did want to acknowledge that we are prophylactically treating a lot of these lesions with surgery. Not every lesion in every joint in every horse is going to result in a clinical problem. Some of these OCDs, by the time we get them to surgery before sale, the joints are effused, they are puffy, so the lesion is becoming clinical. But the goal is really for us to remove lesions that are at a known and reasonable risk of being associated with lameness down the track, minimises the risk of secondary changes in the joint, and reduces the likelihood of us losing days out of training due to lameness or time out spelling from surgery and rehabbing. So that's all I've got. I just wanted to acknowledge Dr. Penny Dow, our radiology department head, for all of the lovely radiographic images that we've used in this study. Cool.
Does anyone have any questions?
Just with sesamoiditis, say like a week at survey time at the moment, mild sesamoiditis, what's the likelihood by yearling cell time that would have resolved? There's no, it's just a bog standard, or does it take till this sort of 2 or 3 for it to be resolved?
Some of them tend not to completely resolve, like you'll still x-ray them at 3 or 4 and those changes are there. I guess the goal is to try and minimise it from getting worse. It doesn't tend to resolve completely, I would say, in my experience.
And from the sort of weaning stage to yearling stage, do they likely get a lot worse?
Some of them can, not a massive proportion. We tend to try and recommend watching your weight on these horses and the amount of exercise that they're doing. That's probably our biggest recommendation that we have with them. There are certainly other treatments out there that people are doing, aspirin, shockwave, that sort of thing. But probably the most important thing is watching their weight. If we're picking it up quite early, the foals are still on the mare. Sometimes we're x-raying them for other regions. You may even sort of try and wean the foal a bit early if it's quite heavy.
And the majority from it is from concussion or natural?
Yeah, I mean, the name suggests it's inflammation, but really it's probably more likely that concussion loading through that bone and an adaptive or maladaptive sort of response to that.
Thank you.
questions for Amy?
Still awake?
All right, well,
Thanks, guys.